Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. How are my dear students? Hope you will be fine and in good status of health. I always start my presentation lecture with this prayer. Allahumma arfa annal bala'a wal bala. ऐ मेरे प्यारे अल्लाह हम सबको हर किस्म की आफत और बला से महफूज रख, आमीन. This is our third lecture considering the diseases of scrotum and testes. In the previous two lectures, I have discussed with you the cystic swellings of the testes and proceeding to the some congenital and diseases affecting the earlier life of male patients. Today I will discuss with you malignant conditions of the testes, and the pattern will be same, that I will try to involve you with this discussion and you will be the active partner in this discussion. So as I said previously, today we will discuss cases of testicular tumours. Well, basically, this is a case in which a patient, usually adult patients, can be at 20 to 40 years of age, presents in the outdoor department with the history of painless enlargement of one or two balls, and he is concerned about its nature of pathology. Before discussing that pathology, I will briefly discuss with you some important points. Mind that testicular cancer forms 1% of all malignancies in the males. Although this seems to be very low percentage, but it is a very important that we should know something about this disease, because by diagnosing this condition, treating surgeon can cure this disease. Regarding overview of this disease, you should know that cancer of testes are relatively rare cancer, accounting for approximately 1%, as I told you. However, it is important in field of oncology that it represents a highly curable neoplasm, and the incidence is focused on young patients at their peak of productivity. Regarding its epidemiology, regarding age for these tumors, median age at diagnosis is 34 years, with 50% of incidence lies between 20 and 35 years. In a man with older age, 50 years of or above, solid testicular mass is usually lymphoma. Regarding this age, we can say that there are three peaks: one between 2 to 4 years, second peak is 20 to 40 years, and the third peak is 50 years. And the peak between this 20 to 40 years is the maximum percentage of involvement with this condition. While geographically there is highest incidence in Denmark, Norway, and Switzerland, and it is lowest in the Eastern Europe and Asia. While it is common in young white men as compared to African American, means black races. Regarding, because a male has two testes, so what about its laterality and bi-laterality? Meaning that, does this involve one side or it involves both sides of the testes? Regarding its involvement, it is slightly more common in the right testis, while 2 to 3% of tumors are bilateral, occurring either simultaneously or successively. While similar histology predominates with bilateral tumors, and bilateral seminoma is the most common histological types. Mean that if it is bilateral, seminoma will be in 50% of cases in these bilateral tumors. While germinal tumors with different histology were present in 15% of the total cases. So then there are some predisposing factors. You are well familiar of those. Number one is cryptorchidism. Last time we discussed this cryptorchidism. Can you tell me what is cryptorchidism? Yeah, yes. What is it? Yes, it is combination of two words. Words, cryptos mean hidden and testis mean testis. So these are hidden testis, cases of undescended testes. So I discussed with you that undescended testes are predisposed to malignant transformation. Second variety is Klinefelter syndrome, and in third predisposing factor is positive family history. Then positive personal history, meaning that if one has involvement on one side or prostatic tumor or vascular tumors, they can have testicular neoplasm also. And then trauma, viral infection, hormonal factors, and exposure to environmental estrogens are also seems to having a predisposition for the testicular malignancies. So what is Klinefelter syndrome? Can anybody tell me what is Klinefelter syndrome? Think. Tell me the answer. Yeah. It is a genetic condition in which person will be having 47 chromosome and with double X and Y combination. This is the set of symptoms that results from 2 or more X chromosomes in the males. And its primary features are infertility and small testicles. So what is the classification of these testicular cancers? Classification is roughly with germ cell tumors, non-germ cell tumors, and the secondaries. Among germ cell tumors, which constitute 90% of malignant tumors, seminoma, non-seminoma like embryonal cell carcinoma, choriocarcinoma, teratoma, yolk cell tumors are there. And third variety is a mixed variety, which is both seminoma and non-seminomas component. These constitute 90% of malignant tumors. While among non-germ cell tumors, which is rare, these are usually benign. This involves tumor arising from the Leydig cells and Sertoli cells. And testes are also the sites for the metastasis like leukemia, lymphoma, or mets, mostly from the prostatic cancer. These can manifest or having metastasis in the testes also. So what is the cross section or anatomy of the testes? You know, testes having a basically two components. One is stroma, which is encircling or giving host to the seminiferous tubules, and the number of seminiferous tubules are between 200 to 350 tubules. So two components, one is seminiferous tubules, the other is stromas. So tumor can arise from both of these, as I initially. So a tumor can arise from both of these components, While stroma with interstitial cells, they are of two types, Leydig and sertoli cells. On gross appearance, two main varieties of testicular tumors, which comprises 90% of malignant tumors. This is the cross section of all types of tumors. I will discuss you later on with the condition having this cross appearance. So, testicular tumors, starting with a brief discussion about testicular tumors. The foremost, which comprises about 90 to 95% of testicular cancer, are germ cell tumors. So these are divided into two types. One is seminomatous germ cell tumors, while the second variety is non-seminomatous germ cell tumors. Among this, seminoma, which is the most common testicular tumor, and it is slightly at the more advanced stage or age of the patient as compared to teratoma. Usually it is from third to fifth decade of their life, but it has a better prognosis as compared to teratoma. And the common factor is that it is both radiosensitive and chemosensitive, or its chemosensitivity and radiosensitivity is better than the other parts of the testicular tumors. This is the cross section. You know, this shows this fleshy tumors, and when you will cut this testis, it will show yellowish fleshy tumors. Like so, seminomas are further classified into different varieties. One is called typical seminoma, which is about 85% of these tumors. Second variety is anaplastic, which is about 10%, and spermatocytic, but it is have a better prognosis. The second common variety of germ cell tumors are teratoma. It is so called because it is composed of all three germ cell layers, and it can involve any age group. While on ultrasound, it has a large and homogeneous mass, as this picture is showing. This is the ultrasound pictures of a testis, and this is a tumor involvement of the testis, and this is large and with various signals. While the cut section usually shows the cystic components more as compared to seminomas. Look at these. These are the cysts present in this tubular and testicular nucleus. So, with this brief discussion, when a patient comes to you, how will you be able to diagnose this as a case of malignant testicular swelling, and what can be the signs and symptoms of testicular tumors? Regarding its clinical manifestations, the usual presentation of a testicular tumor is a nodular or painless swelling in one of his gonad. This is the most common clinical presentation of a patient having this malignant condition. Sometimes, on rare occasion, infertility is the presenting complaints. While the patients having mass, 30 to 40% may complain of a dull ache or heavy sensation in the lower abdomen, anal area or scrotum, in spite of telling that one of his testes is enlarged. While in 10% of cases, acute pain can be the presenting complaint for these tumors. So what should be your examination with this sign and symptoms? It should be a bimanual examination of a patient, and but remember that you should always examine the normal side first and then doing the examination on the involved sides. On examination, any firm, hard or fixed area should be considered suspicion. While testicular tumors tend to remain ovoid, being limited by the tough investing tunica albuginea. While in rare cases, a hydrocele may be present and increases the difficulty of palpation. In this case, it is called a secondary variety of hydrocele. But those are rare cases. So, dictum for any solid scrotal swelling is that all patients with the solid, firm intratesticular mass that cannot be transilluminated should be regarded as malignant unless otherwise proved. So we should be well familiar of this dictum. So, having made a clinical suspicion of testicular tumor, the next important question is, what is the stage of this tumor? Are you familiar with staging? There are some staging systems. What are those? But before discussing, I will discuss with you the requirements for this staging. To properly stage testicular tumors, some things are needed, and what are those? This is good clinical history with clinical adequate examination, pathology of the tumor specimen, which is done after radical inguinal orchiectomy, then some radiological procedure which involves ultrasound both of testes and abdomen, then CT examination with MRI and bone scan, while last one is tumor markers, which includes alpha fetoprotein and beta component of human chorionic gonadotrophin levels. The first staging is, which is called clinical staging. It is very simple, and to start with is that there are 4 stages, clinical stages. Stage 1, in which tumor is only confined to the testes, while stage 2 is having a nodal disease, but it will be confined to below the diaphragm, meaning that abdominal lymphadenopathy associated with testicular swelling will be the stage 2, while in stage 3, nodal disease will be above the diaphragm, meaning chest lymphadenopathy or cervical lymphadenopathy, while stage 4 will be of non-lymphatic metastatic disease regardless of the lymph node involvement. Then there is another more elaborated staging system or classification system, which is by American Giant Cancer Oncology Group. This is called on the basis of TNM staging system, and for primary tumors there are these levels 1, 2, 3, 4, 5, 6, 7 with PTX, where primary tumor cannot be assessed with PTO, with no evidence of primary tumor, and PTIS, which denotes intratubular germ cell neoplasm, which is called carcinoma in situ, while PT1 is tumor limited to the testes and epididymis without lymphatic or vascular invasion. PT2 is tumor limited to the testes and epididymis with vascular or lymphatic invasion, a tumor extending through the tunica albuginea with involvement of the tunica vaginalis, while PT3 is tumor invades the spermatic cord with or without vascular lymphatic invasion, while PT4 is tumor which invades the scrotum, scrotal skin with or. While this system, when it addresses the regional lymph nodes, again it is of 5 types with NX where regional lymph nodes cannot be assessed, with N0 no regional lymph nodes metastasis. N1 signifies the metastasis in a single lymph node groups but having a size less than 2 centimeter in greatest dimension, while N2 metastasis in a single lymph nodes having a size between 2 to 5 centimeter in greatest dimension, or multiple lymph nodes less than 5 centimeter in greatest dimensions, while N3 are metastasis in a single lymph node groups but having a size greater than 5 centimeter in dimension. While this staging for distant metastasis, again there are 5 groups with NMX. Presence of distant metastasis cannot be assessed, while with M0 where there is no distant metastasis, M1 with distant metastasis, which further divided into 2 types, M1A, M1B. M1A is non-regional lymph nodes or pulmonary metastasis, while M1B is distant metastasis other than the non-regional lymph nodes and lungs. So this American Giant Cancer Committee has described staging system on the basis of TNM system. Having staged this disease, what are the investigations required for this disease? Number 1 is ultrasound. Number 2 is tumor markers with imaging, and imaging includes chest radiograph, ultrasound, which is for both testis, abdomen, and it is the gold standard. It is also complemented with CT examination, which is again for both abdomen and chest, and then MRI of the abdomen. What are the tumor markers for this disease? As you know, what is the role of tumor markers in this disease? It helps in diagnosis. 80 to 85% of testicular tumors have positive markers, and among these most of the non-seminomas have missed tumor markers. Only 10 to 15% of non-seminomas have normal marker level, while if after archiectomy, if markers elevated, it means that there is residual disease of stage 2 or third disease, while elevation of markers after lymphadenectomy means a stage 3 disease. While degree of marker elevation appears to be directly proportional to the tumor burden, and it also indicates histology of the tumor, if means that if alpha fetoprotein elevated in seminoma, it means tumor has non-seminomatous elements, while negative tumor markers becoming positive or follow-up usually indicates recurrence of tumors. And very importantly, markers become positive earlier than the X-ray studies. So tumor markers have very important diagnostic and prognostic value in case of tumor testicular malignancies. So what are the types of markers? There are 2 main classes. One class is oncofetal substances, which involves alpha fetoprotein and human chorionic gonadotrophins, while the other component is cellular enzyme, which includes LDH and LAB, which is for alpha fetoprotein trophoblastic and human chorionic gonadotrophin. These are the main tumor markers which are done in testicular malignancy. Then what are the imaging studies for the testicular malignancies? Yes, first is plain X-rays. And what does it show? It shows metastasis. Look at the X-ray of this. Where is the malignancy? This is usually in the shape of cannonball. This is a secondary in case of testicular patient was having a history of testicular tumors. X-ray is showing the appearance of cannonball in his brain radiograph of the chest. What is the next investigation? Okay, tell me. This is ultrasound, and ultrasound, this is the ultrasound of the involved side of the testis of a patient with testicular tumor. You know, this is a normal substance of the testis, and this hypodense area is signifying the solid testicular region in this patient. What is the next investigation? It will be CT scan. CT scan is mainly done for the metastasis. Stage this for detection of lymphadenopathy, extranodal metastasis in the lung and liver, and if nodes less than 1 centimeter, suspicion effect at the site of drainage. For example, at the renal fibula of left kidney, aortocaval junction. What is the next investigation? Next is in MRI. This is done in very rare cases. It usually has no important clue in case of diagnosis of testicular tumors. You know, again, this is a hypodense area in the testis as compared to rest of the testicular tissues. This is on P2 images. So after diagnosis and staging of the tumor, what is the treatment? But before going to the treatment, I will tell you some important principles which should be aimed at one stage above the clinical stage. This is in form of radical inguinal archaectomy is standard first line of therapy. It is for both the diagnosis and for the curative aspects. While lymphatic spreads, you know, initially goes to retroperitoneal nodes, and it should be lymphadenectomy associated with testicular surgery, mean that associated with archaectomy. While early hematogenous spread is rare and bulky retroperitoneal tumors are metastatic tumors, initially you should downstage with chemotherapy, and for seminoma you should remember that these are more radiosensitive, so treat with radiotherapy, while non-seminomas are radio-resistant and best treated by surgery. Advanced disease or metastasis responds well to chemotherapy. This is a small algorithm for testicular seminomas. And I have discussed with you this under the principles of treatment of testicular tumors. So survival in testicular tumors, it has improved overall survival in the last 15 to 20 years, mainly because of better understanding of natural history and pathogenesis of disease with reliable tumor markers and very important chemotherapeutic agents which has been incorporated in chemotherapy for these patients, which is cisplatin based chemotherapy. I would like you tell about some important celebrities worldwide which had involvement of testicular malignancies and which had been cured with adequate treatment. Now they are living their good life, normal life. One is the famous cyclist and he had been cured, now living his normal life. And the other is famous Indian cricketer, which was famous for his hard hitting, and he had also a few years back involvement of testicular malignancies, had been cured and now passing his normal life. And after the disease he was again selected for his national team. So with this I will end up with my presentation, and what we would like to end this presentation is that with famous saying of Benjamin Franklin, which was an American president, that well done is better than well said, meaning that a proper examination and diagnosis of this malignancy can save a life of a patient with involvement of this tumor. And with this message to all males, that please protect your hair. With this, a bimanual examination important. I would like to end with again prayer that may Allah protect you and save you from all types of calamities, you and your beloved one. Thank you very much. Allah Hafiz.